Good afternoon and welcome everyone. My name is Nicole Sadler and I'm a clinical psychologist and the Head of Policy and Practice at Phoenix Australia Centre for Post-Traumatic Mental Health. Phoenix Australia is a not-for-profit organisation and for 25 years we've been dedicated to reducing the impact of trauma and post-traumatic mental health problems in individuals, work groups and the community. Thank you for joining us today to discuss trauma-informed practice in aged care, practical strategies. I'd like to start our session today with an acknowledgement of country. I acknowledge the traditional owners of the land where I'm situated today, the Wangari people, and those of the land where each of you is situated. We acknowledge that the lands on which we meet were the place of age-old ceremonies, of celebration, initiation, and renewal, and that the local Aboriginal peoples have had and continue to have a unique role in the life of these lands. Let me now briefly outline the background to this project and how today's webinar will run. Phoenix Australia is one of 4 organisations funded by the Australian Government Department of Health to deliver a COVID-19 grief and trauma response package to the aged care sector. The other organisations are the Australian Centre for Grief and Bereavement, Dementia Support Australia, and the Older Person Advocacy Network. Today's webinar is part of Phoenix Australia's program of work under this funding. This is the third in a series of 4 webinars. The first, Identifying and Managing Trauma within the Aged Care Sector, was held in November 2020. In that webinar, we provided information on the impacts of trauma, including for those in residential aged care, and how applying trauma-informed strategies can assist residents and their families, carers, and managers. In the second webinar, which was held in February this year, we explored the interaction between dementia and trauma. In case you missed either of those webinars, we'll send you links to the recordings along with the link for today's webinar. During today's webinar, our panel of trauma experts and advocates for older Australians will introduce the principles of trauma-informed practice in the aged care context and discuss a range of practical strategies and tools that individuals and organisations can consider when introducing this approach. Following these short presentations, we'll have a panel discussion and then there will be an opportunity for you to ask the panel some questions. Just before I introduce our panel members and we start the presentations, I'd like to cover some housekeeping to ensure you have the best experience today. As you can see on your screen, there are 2 boxes below the webinar stream. One is a chat box where we encourage you to comment and chat with each other by entering your name and clicking Join Chat. The other is a Q&A and polling feature. We encourage you to ask questions, but also to vote for questions you would like our speakers to respond to. You can do this by typing your question and either entering your name or leaving it blank if you wish to remain anonymous. Should you see a question you want to vote for, hit the like button to help ensure that we answer that question today. There will also be a poll towards the end of the event. Please complete this by navigating to the Polls tab within the Q&A. I'll let you know when the poll is launched at the end of this webinar. Should you experience any technical difficulties, please navigate to the chat box at the bottom right of the page and our team will be able to assist you immediately. Now I'd like to introduce our presenters and panel members. First of all, Anne-Laure Quinault. Hi, Anne-Laure.
Hi.
Anne-Laure is our Director of Policy and Service Development at Phoenix Australia. She's a psychologist and leads Phoenix Australia's work to promote best practice and service improvement for organisations that support people exposed to trauma. She has extensive experience in the field of complex trauma and interpersonal violence. Next, I'd like to introduce Dr. Ros Lethbridge.
Hi, Nicole. Hi, everyone.
Hi, Ros. Ros is a clinical psychologist with expertise in trauma from a clinical, educational and organisational perspective. She's worked clinically for many years with trauma survivors from high-risk organisations, with the judiciary delivering education programs on family violence and vicarious trauma, and with high-risk organisations delivering mental health strategic reviews. And she's leading a component of Phoenix Australia's current work to deliver trauma-informed care resources to the aged care sector. Now I'd like to introduce Dr. Richard Bonwick. Hi, Richard.
Good
Richard
afternoon.
Richard is a psychiatrist who specialises in old age psychiatry and treating ageing war veterans. He's spoken and written nationally and internationally on a variety of topics in old age psychiatry. He's an expert clinical advisor to Phoenix Australia and an honorary clinical senior lecturer at the University of Melbourne. And finally, I'd like to introduce Deborah Nicol.
Thanks, Nicole. Hello, everyone.
Hi, Deborah. Deborah is an advocacy manager for Elder Rights Advocacy. She's dedicated to advocating for the rights of older people to access and participate in the care and services that they're entitled to receive. Her motivation comes from a strong desire to alleviate the powerlessness, inequality, and injustice experienced by older people and their representatives. Deborah has a deep knowledge of the aged care sector and the legislative framework in which it operates as a result of her 15 years at the Elder Rights Advocacy and previous work in aged care service provision, including residential aged care facilities in the community and in palliative care units across Queensland, South Australia, and Victoria. Great to have you with us today, Deborah. I'd now like to invite Anne Law to give us an overview of trauma-informed care and the different tools and resources being developed under this project. She'll then hand over to Ross and Richard, who will give us a presentation on some key trauma-informed care principles and practical examples of their application in the aged care sector. Thanks, Anne Law.
Thank you. So if you can bring up the slide. So as Nicole mentioned, I'm going to provide you a little bit of background on the package that we're offering and then give you a definition of trauma-informed care. Next slide, please. So as Nicole mentioned, we're one of 4 organizations that's been funded by the Australian government. 2 organizations are providing practical support to either facilities or individuals affected by COVID-19 grief and trauma, and that's the Australian Centre for Grief and Bereavement and Dementia Support Australia. We are providing a different sort of service, which is we're developing resources to support the sector and in supporting all those people recovery following trauma. And that's trauma either from a lifetime ago, so it might be childhood trauma, it might be more recent trauma like COVID-19 or elder abuse. We're also providing resources so that the well-being of staff working with older Australians is supported as well. And the whole package, as we said, is also supported by the Older Person Advocacy Network, who is disseminating the information in this package to older Australians, their loved ones and families. Next slide, please. So as part of the Phoenix package, we've been tasked to develop information for older Australians, their families and loved ones to support their recovery following trauma. And that will include things like tip sheets and videos and animations. The biggest part of our package, though, is to support the aged care workforce and helping that workforce being trauma-informed to support older Australians to recover from the impacts of trauma. And we've created a range of resources already, so tip sheets and a training course, a trauma awareness course. And we're about to develop a whole range of in-depth training courses around trauma-informed care and in supporting people following exposure to trauma. We're also in the process of developing a well-being program for staff working with people affected by trauma or that have themselves been affected by trauma. And we'll have a whole range of animations to keep the workforce informed about trauma-informed care as well. Next slide, please. I just want to give you a bit of a definition of trauma-informed care. Trauma-informed care is very important because we know that older Australians accessing aged care services are likely to have experienced at least one traumatic event in their lifetime. And that while many of them will recover, for some of them, they will have lifetime impacts from that traumatic event. We also know that many older Australians are vulnerable to trauma as they grow older. For example, elder abuse, COVID-19, the isolation, the loss that they've suffered through COVID-19. And so it's really important to have from an organizational point of view, from an individual point of view, a way of working with older Australians that is responsive to their needs when they've been affected by trauma. And first of all, trauma-informed care is a strengths-based approach. That means that when thinking about people and the impacts of trauma, we know that people have ways of coping with trauma, that they have resources, behaviors, networks that help them cope, and that to be trauma-informed, we need to respect and harness those resources, those coping mechanisms. The other thing that's important with trauma-informed care is that we need to understand the behaviors of people in light of their experience of trauma, so that we understand that trauma has physical, psychological, emotional impacts, and that will impact on how people behave in aged care settings. So when we see someone being agitated or refusing care, it may be because of the impacts of trauma, and there may be a very good reason why they feel like they're acting the way they are. The two things that are really important to trauma-informed care is creating safety at a psychological and emotional level for people that have been through a traumatic event, but also for the staff that support them. And the other important aspect of trauma-informed care is to ensure that people affected by trauma have a sense of choice and control, that they feel empowered as they access services, because we know that feeling in control and empowered really supports recovery from trauma. And that's a really important aspect of it. Next slide, please. So in the context of aged care, for us, trauma-informed care, we're going to talk to you about individual practices that individual workers can have that supports an older person affected by trauma. But more importantly, we'll talk about organizational practices that will support staff and older people in feeling safe following a traumatic event and feeling like they have some control and power. The other thing that's really important about trauma-informed care is that everyone has a role in being trauma-informed. This is not a practice that's just for counselors or for specialists. It's anyone from someone on a reception desk, some of the cleaning staff, personal care workers, to the managers or the executive leadership in an organization. Everyone needs to be trauma-informed in their practice. And a very important part of trauma-informed care is to support the older person's well-being, but also workers' well-being. Workers that feel safe, whose well-being is looked after, are more likely to be trauma-informed and supportive of older people recovering from trauma. And finally, we want to make sure that that you know that trauma-informed care is nothing new to aged care. Aged care for a long time now has really worked within a person-centered model, and that trauma-informed care very much aligns with that and is very similar to person-centered care. It just has that additional lens of looking at trauma. And that what Roz and Richard and the panel will talk to you about particularly is that it's critical during the transition into aged care services, that often people affected by trauma will struggle with the transition process into aged care, and having processes, practices that support trauma recovery during that period is particularly important. I'll now hand over to Roz to really talk in more detail about trauma-informed practice and the principles underlying trauma.
Thanks, Anne-Laure, and welcome again to everyone watching and listening to this webinar today. So, as Anne-Laure said, I'm going to discuss the 4 principles of trauma-informed care as they apply to residential aged care settings, including practical considerations for people working in residential care and for the aged care organisation itself. Next slide, please. So the slide that you can see in front of you sets out the 4 trauma-informed care principles. So we at Phoenix have tailored the key principles of trauma-informed care to the aged care sector and simplified them down to these 4 principles. So you can see the first one is understanding the effects of trauma, promoting safety and trust, providing choice and control, building connections, and promoting quality of life. Now, I'm going to discuss each of these principles in turn in a moment, and I'm also going to talk about some of the practical considerations that underlie them. But first of all, I'd like you to notice that there are 2 other approaches embedded in each of these principles. The first one is person-centred care, which was mentioned by Anne Law, and the second is culturally safe care. Now, as Anne Law mentioned, and for most of you attending today, you'll know that person-centred care has become central to aged care and is emphasised in the 2019 Aged Care Quality Standards. Person-centred care really forms the foundation of trauma-informed care, where collaboration and informed decision-making are key aspects. So trauma-informed care extends that person-centred approach by emphasising the role of trauma in shaping a resident's experience of care. As we understand it, aged care facilities are already facilitating person-centred approaches to care. So tying trauma-informed care to person-centred care should make the implementation of trauma-informed care much easier. The second concept you can see, which is embedded in these 4 principles, is culturally safe care. And it's also likely that you're very familiar with the concepts of cultural safety, cultural competence, and cultural sensitivity, which is basically having the understanding, knowledge, and skills to work within a person's culture and respecting and taking into account diversity. Next slide, please. So in relation to diversity, I imagine that everyone here is aware of the aged care diversity framework, and we can see that represented on the slide in front of us. It identifies a number of groups with high prevalent rates of trauma. These groups are also at increased risk of experiencing trauma as they engage with aged care services. For example, if the aged care environment is too institutionalised, it can feel less safe for groups like the Stolen Generation, Forgotten Australians, and also for military veterans. So I'll now go and summarise the 4 principles of trauma-informed care. Next slide, please. So first, we have principle 1, which is about understanding the effects of trauma. Now, the key elements of this principle are that staff understand that trauma is common, that trauma can change behaviour, that aged care can be a reminder of past trauma for people, and the importance of assessment and planning to reduce trauma effects in residents. So if we have a look at the quote there on the screen in front of you, you can see May, a lifestyle coordinator, is saying, "It's helpful to know what has led to the way people are. You feel more empathy. Otherwise, you can end up blaming them for their behaviour." Next slide, please. So the practical implications of this first principle is to teach trauma awareness to all aged care staff, as well as an understanding that traumatic experiences are common. The aim is for everyone working in residential aged care to understand what the effects of trauma look like in residents and, of course, as Anne Law mentioned earlier, also in staff. Training on this particular principle will help staff to both recognise and then respond to the common signs of trauma, both at the initial assessment or admission of the resident and also when caring for residents. Now, Richard Bonwick will speak after me in more detail about the importance of taking a trauma-informed personal history on admission. But that information about a resident's trauma history and how it might impact on their needs and on their preferences can be shared and communicated with all staff who care for that resident. Under this principle, training in cultural safety can also be expanded, as it helps staff to identify trauma triggers common to specific communities, such as the communities I mentioned earlier in terms of the aged care diversity framework, and also how different communities may view trauma and mental health. Next slide, please. So coming to the second principle, it's about promoting safety and trust. So when you have a traumatic experience, you can lose trust in the world and also trust that good things will happen to you. So entering an environment where trust can be established leads to feeling safe. And by that I mean both physically and emotionally safe. This is important for residents and for their families, and of course also for the staff working within the aged care facility. Now, the key elements of this principle are to create a safe environment, to match information that's provided to a resident to their capacity to understand it, to provide transparent care, which is doing what you say you will do. It's about treating the residents with respect and dignity, and also compassion and kindness, and supporting staff safety and well-being. And we have a quote here, we haven't attributed it to anyone, but I would say it's probably from a personal care worker, saying that I know when I take the time to have a chat with Mr. P, he's much more relaxed and comfortable with me touching him. It may only add a few minutes to my job, but it's worth it. Next slide, please. So what does promoting safety and trust look like in practice? Well, we could see from the previous quote that spending time with residents, and we know time is in short supply, but spending time can help promote that sense of safety and trust for people. For staff or for the organisation itself, it's to ensure that staff are trained in using simple strategies like explaining what they will do before providing care, so that even unidentified trauma survivors are protected from reminders of traumatic events. For example, for survivors of sexual assault, providing intimate care such as showering can be quite triggering or remind them of past traumatic experiences. In practice, this principle means providing information and care that reflects the resident's needs and capacity, and providing that care with respect and with compassion. So training around this might include simple strategies to help reduce or contain the distress of a resident. And coming to the more physical design of the facility, that would support privacy, autonomy, and of course, cultural safety. Under this principle, there's also a focus on the importance of promoting staff self-care. So, for example, this might be regularly discussed in staff meetings or in staff supervision. The well-being of staff impacts on their capacity to care for residents. And of course, it's intrinsically important in itself. Next slide, please. So coming to the third principle, the principle of providing choice and control through collaboration. So when you go through a traumatic incident, which might have included the experience of COVID-19 in the residential care context, your sense of predictability can be lost, or you might lose a sense of control of yourself and also a sense of control of the outside environment. So this principle is about providing a service that gives residents a sense of efficacy and personal control over their lives. Key elements of this principle are facilitating the voice of the resident, providing informed choices for residents, asking for permission, and collaboration in decision-making between the residents, their families and carers, and the facility. And we have a couple of quotes here from Jane, the nurse unit manager. Locks on doors, windows that don't open, shutting doors at night, they can all increase feelings of lack of control and not being able to escape, especially for trauma survivors. Residents with dementia lose the last language they learned, usually English, so they go back to speaking their first language, and communication is a challenge. So flowing from that, we have some practical strategies that relate to this principle. Could we have the next slide, please? And I note here that a lot of the content of person-centred care promotes this particular principle of providing choice and control. So a practical implication of this principle means that whoever's interacting with a resident gives them a sense that they have control over their body. Now, look, this is a particular challenge in aged care when staff are doing things for older people and to older people. So training can support staff so that they know how to ask for permission and how to involve residents and their families and their loved ones in decisions about their care. Care plans become quite important under this principle. And in fact, the care plans are important under all of the principles. So they capture the residents' preferences so that those preferences can be accommodated. From an organisational perspective, processes can be developed to ensure that all staff have access to these care plans, or perhaps the relevant parts of the care plans, or perhaps the case notes where these preferences are recorded. Now, remembering back to the nurse unit manager's quote about English being lost, we know that that can happen in dementia, it can happen when people are stressed, and it also often happens for older people. So in that context, from a practical perspective, it's really helpful to have interpreters and bilingual workers available. They can be used to support that transparent communication with residents. Next slide, please. So this final slide looks at building connections, focusing on strengths and promoting quality of life. So Anne-Laure outlined earlier that trauma-informed care is a strengths-based approach. So that means that the caring focuses on an individual's existing strengths and resources rather than their disability. Applying this principle, residents can be more independent and ideally thrive when they use their existing routines or their existing resources, can focus on achieving goals, and also when they're assisted to form and to maintain relationships. And if we look at the quote here from Angelica, a personal care worker, Jack has dementia and challenging behaviour. We see that use of the word challenging. We encouraged him to join staff in walking the facility's dog. His behaviours changed because he was listened to and formed relationships with staff and people in the community. So we can see within that quote, it's a really nice practical example of how that principle might look in practice. Could we have the next slide, please? So what does this last principle look like in practice? Well, it involves staff engaging with and building relationships with relationships, as well as supporting residents' connections, both within and external to the facility. So coming back to the care plans or the notes being relevant again, resident strengths and coping mechanisms can be identified and recorded by staff, and practical support can be provided for residents to pursue their preferred pastimes. For this to work well, all staff need to access this information on an ongoing basis. From an organisational perspective, under this principle, residents are assisted to access external care and services. So this might involve healthcare or professional mental health supports. So that concludes my overview of the principles of trauma-informed care and a summary of what they might look like in practice. I'd like to hand over now to Dr. Richard Bonwick, who's going to talk about taking a trauma-informed history on admission to an aged care facility. Thank you, everyone, and thank you, Richard.
Thanks, Ros, and good afternoon to everyone who's listening and watching. As a medical doctor, I know that obtaining accurate information at a hospital admission is essential for me to provide optimal care. You wouldn't want to be treated for an illness by a doctor who hasn't fully assessed you and your medical problem. And the importance of staff gathering information is no different for a new resident entering an aged care facility. Only with accurate information can the best care plan be developed. This all takes time, effort, but only a little expertise. And gathering is a good word, as it often requires exploration beyond just spending time with the new resident. It usually requires making time to talk to a close relative or partner or other key support. Often accurate medical information, such as what diagnosis the resident has, what medications being prescribed, which medical practitioner is providing treatments, etc., and physical care needs, such as the need for assistance with showering, dressing, feeding, mobility, etc., is sought, and it's well sought by those who are admitting the person to the aged care facility. This is then carefully documented, integrated into the resident's care plan. This is generally done very, very well. But often psychological issues are not focused on to the same extent, and this lack may be even more apparent in obtaining a trauma history to allow trauma-informed care. To put this in perspective, imagine providing care for a resident with a history of being a refugee from a war-torn country, or a recent history of being assaulted. Without care staff having this information, I don't think care or how it is provided could be anywhere near optimal without that very important piece of information. A word about who should gather a trauma history. I could argue that the hours spent in this task are arguably the most important time of any spent on providing care. So I think this task should be undertaken by a senior staff member, and it should be one of the most important tasks they perform. If that requires additional staff time allocated to this task, then this should be supported by management. Accurate information initially will be rewarded 100 times over during the resident's stay, and that stay often lasts many years. So where to start? Those who attended the first webinar will recall my comments on the trauma attached to entering an aged care facility. As a general rule, residents rarely enter an aged care facility by choice. An entry usually follows at least one traumatic event. So I would suggest beginning a trauma history by focusing on the reasons and the recent history resulting in the resident's entry to an aged care facility. New residents can generally provide at least some details, and it may allow a picture to emerge of their previous life and to aid in settling the resident into their new and foreign environment. It also supports the beginning of establishing a good relationship between the care team and the new resident. Start with simple questions such as, what is the story behind how you got here? Then further exploring if it was a physical or mental decline that led to difficulties coping with independent life. Was it the loss of a long-term partner and subsequent loneliness, or was it related to an acute medical event, for example, a fall and consequent injury, or was it another reason? If you can put yourself in the shoes of a new aged care resident, I think it must be a terrifying experience entering an aged care facility. Think how you felt when you were last admitted to hospital. Everything is confusing. What should I expect? What are the rules? Being able to explain your story reduces these feelings and provides an opportunity to allay fears, to some extent at least, and to later rest any incorrect assumptions. For instance, many new residents think, now I'm locked up, I'll never be allowed out, never allowed out ever. Taking this trauma-informed approach will help to establish trust and also make the resident aware that you really want to know their story, even the difficult parts. Next, I would explore the resident's childhood. This may seem counterintuitive or even irrelevant in an aging new resident, but the pattern of trauma through life is often established in childhood. A traumatic childhood is often followed by multiple traumas in adult life. Secondly, the time distance from childhood to late life may make this an easier starting point in discussing past traumas. Another simple starting question could be, how was your childhood? Did you have any difficulties? Then by asking broadly about parents and siblings, further common childhood traumas may be unearthed. Then I would move to asking the story of their adult life, listening carefully for any big clues of trauma. Refugee or migration experience, military service, serious accidents, serious relationship problems. At this stage, the resident may or may not expand on particular issues, but you should note these events, possibly for later exploration. Most new residents will have aspects of this story they are reluctant to share, but I am always surprised how willing people are to discuss difficult topics, such as past personal traumas, if they're given an opportunity. There are a couple of basic rules in obtaining a trauma history. These are very personally sensitive matters, so the importance of privacy cannot be overstressed. It is essential to conduct this interview in a private place, not a public place, such as an aged care facility lounge or dining room. And you must go at the pace the resident wants. A trauma history cannot be rushed. Be prepared to pause, stop, and if necessary, come back later. And finally, I would stress the importance of accessing additional information, but only with the new resident's permission. I think an interview with a partner, family member, or carer is essential. Preferably, this should be done with the resident present and with the clearly stated objective of obtaining further information relevant to the care required in the aged care facility. The final step in the process is integrating the trauma-informed history into the care plan. You may go away, wish to consider the story that you've heard, consider how this will influence optimal care, develop a care plan, and then come back and discuss this with the resident. For example, you described experiencing an assault. Could that make you sensitive to staff physically assisting you with showering and dressing? How could we help you without causing you any distress? Another important issue is how this essential information is recorded so that both the information and the plan is readily available for all staff caring for the resident. Staff who are regular, staff who are infrequent, or even staff doing a single shift. You'll all have your own ideas about this, but care plans I've seen can be lengthy and sometimes confusing. So, a brief summary, say 1 page, with key information to allow trauma-informed care could be prepared. This all sounds time-consuming, But as I said earlier, time spent developing a comprehensive and trauma-informed care plan will be rewarded throughout the resident stay in the aged care facility in so many, many ways. Thank you, and I'm going to pass back now to Nicole.
Thank you so very much for those presentations to Anne-Laure, Ros, and to Richard. Very comprehensive overview of the issues. And just a reminder to those people who are watching, please ask any questions. I've already got a couple which have come through, but also vote on if there's any particular questions that you would like to hear our panel answer. But first of all, I'm going to take the opportunity to ask our panel some questions. Anne-Laure, I'm going to start with you. Given all of that information and that wonderful advice that has been given, if you were to prioritise just 3 or 4 key practices that contribute to trauma-informed organisations, what would they be?
I think that Richard's talked about a trauma-informed care plan. I think that's key. So I won't talk more about that, but I think if I would add that to my list as number 1. The other thing I think that's really key to trauma-informed care, and that already happens, I think, through person-centered care, is having a relationship-based care system. So when you're caring for someone, it's based on forming a relationship with that person, that you're not doing things to that person. Because anyone that's had trauma in their life, that's especially trauma at the hands of another person, that's what's really damaging. So having someone with whom you have a relationship is important. And what we say in our training is that every interaction is a relationship and an opportunity for a relationship. You don't need to see someone every day to have a relationship with them. Introducing yourself, saying hello, being warm is a relationship. That means you're not doing something to them, you're a person interacting with them. So that's really important. The other thing I think is what Ros has already mentioned, which is that often we hear the word challenging behaviors, or a person is behavioral. So people are presenting in aged care refusing care, for example, isolating, being agitated or angry, to really try to think about why is that person doing what they're doing? Is there a reason for this? Hopefully you have some clues in a trauma-informed care plan if that's happened. But if you don't have those clues, to have a culture of asking why. And that may mean that at a handover meeting in a residential care facility, whoever runs that meeting asks why. Why is this happening? What might that be happening? I may not know, but there's often a reason behind that behavior. They're not just being difficult. And the final thing that I think is incredibly important is staff well-being and safety. That if you want a facility or an organization to be trauma-informed, staff need to feel safe and supported. And that means that if they have had their own traumatic experience, like being verbally abused by a family member, for example, put down by a manager, that they have somewhere to go and talk about that, and that they have supports in place, and that they're free to talk about these issues in order to really have that relationship-based approach to the people they're caring for. If they don't feel safe, that's hard to do.
Yeah, great. Thanks so much for that, Anne-Laure. And I really like that point that some of the things that the principles that we're suggesting that people can put into place, it's not about doing a whole heap of extra work. It's just slightly changing the focus or the way that you're thinking about doing the things that you're already doing in terms of your care for residents and their families. Deborah, can you please tell us a bit about the role of advocacy in aged care, and particularly from your perspective, the key practices that contribute to a trauma-informed organisation?
Certainly. Thank you, Nicole. The role of advocacy is crucial in aged care. It's crucial in residential care and in the community for people who are receiving care in their home. That can be a great challenge too, of course, to open your door and let people into your own home is quite another matter. And of course we have to bear in mind that when people are entering aged care, whether residential or accepting services within the home, they are at their most vulnerable when they're having to reach out to receive care. So at that point, they do need to know about advocacy, and providers do have some responsibility at that point to let them know and to make referral to advocacy if required. Of course, that is the choice of the older person and or their family or carers, depending on the capacity of the older person to be able to do that. We have a national aged care advocacy program, and that program is delivered by 9 organisations across the country, 1 in each state and territory. Those 9 organisations are members of the Older Persons Advocacy Network, or OPAN. The service that the OPAN other services provide is free, confidential, and importantly, independent. So we can be partial towards the older person and their perceived interests. So it helps to address that power imbalance. It is about giving the older person a voice. It's not about what we think should happen, but rather what they think should happen first and foremost, and again, or their representatives, depending if the older person has a voice that can be heard at this point. Otherwise, it is the family members and the carers, friends, the people who know them best, who speak on behalf of that older person, or of course if they have someone who has a legal authority to speak on their behalf. But the advocates are out there, working with people daily and providing education to community on the rights of older people. And we're very passionate about making sure that older people have a voice throughout this process. And if they are listened to, then that will, of course, help providers and staff deliver the care to them that is safe, not only for the older person, but for the staff as well. And I don't know if I could, add to the practices that my esteemed panellists have already mentioned, but certainly include family representatives in care planning. They know the older person best. It does take more time. It's not just a quick phone call once every few months to say, is there anything else you'd like it put in the care plan or updated? It is about sitting down and having a thorough care plan that says who the person is, where they've come from, and how they want to be cared for. And allow time for staff to have a thorough handover. We are often told that by staff themselves when we do education with staff that they don't get sufficient time. So allowing time for that is also very, very important. And another thing I would just add is about dedicated nursing. We know it works. It works for the older person. They can build a relationship with that staff member. They are dedicated to them. And the staff member also then knows the older person and isn't having to relearn how to interact with that person appropriately continuously. So dedicated nursing is, a good idea, I would say.
Yeah, great.
Thanks, Nicole.
Thanks, Deborah. Obviously, a critical role that you play in terms of advocacy, and you're thinking about it from all of those different levels about how do you engage effectively with the resident, but also their families and also the care staff. Thank you for that. I'm just going to ask one more question, and then we're starting to see some great questions come in from the audience, so we'll get to those in a moment. Richard, you spoke about how important it is to get a trauma history when someone comes into an aged care facility. What about if the person, you suspect that there's a trauma history, but they're not yet ready to disclose that to staff? What do you do to manage that type of situation?
We kind of seems to be the key is information, isn't it? And I guess even knowing that a piece of information may exist is important. So acknowledging that you may be missing a vital piece of information about this person. They haven't been ready to tell us yet. They might have hinted, they might have kind of given the bones of their life story that suggests there could have been issues that crop up. I think it's about making sure that's carefully recorded, the same as actually traumas, spread between the staff so that staff are aware. And hopefully people just listen very attentively, because opportunities arise at all sorts of times and places and locations to gather further information, to explore it. I think I said during my talk, you must go at the resident's pace. And I think that's the key here. Allow people time, allow multiple opportunities, and allow the resident to come to that disclosure in their own time. In my own practice, I've often been quite concerned about patients not disclosing things. Sometimes it can literally take years, even when someone's in therapy, to come out and talk about something that's incredibly traumatic. And so for residents with staff coming and going, it's not surprising that might happen. So I think patience, time, opportunities, and if a chance arises, jump on it. Provide that opportunity for the person to talk.
Yeah, and you know, all great advice. And I think as we've talked about in these presentations, is that most people have a trauma history. So taking the approach where you're thinking that they probably do, and to always approach people with a trauma-informed way in practices is just good way of dealing with people in these facilities. Okay, so I'm going to move to some of the questions that we're seeing coming in through the stream. So thank you to people for starting to put those questions in. One of the questions, Anne-Laure, where can I access the trauma-informed self-assessment that we spoke about earlier in the webinar?
Yeah, so this self-assessment tool has been developed and is in a process of being designed and tested by people that worked in aged care, and it will be available at the end of June because we're trying to make it as user-friendly as possible, and it will sit on the website that will be at the end of our presentation, so that we have a website that will house all of our information, and that will sit on that website. We'll also make sure that aged care facilities and organizations are aware of the self-assessment tool and let their employees and contractors know as well. Yeah.
Great, thank you. We've got a question here about considering the community-based aged care provision in this discussion. Now, just to make it clear that this particular project that we've been asked to do is around aged care, residential aged care facilities, but obviously community-based aged care, trauma-informed care is also very applicable as well. Any particular comments, perhaps Deborah and then Richard, that you might have about how do we apply these types of principles in the community-based aged care sector?
Well, I would think the same principles apply, Nicole. It is about care planning. It is about including the person or their representatives in that care planning, and they'd be considerate of that. And as was said earlier, everyone has had a traumatic experience. By the time we reach old age, we're very fortunate if we haven't, but so we can assume that people have had, and that particularly in the home, providing care in the home, to be very respectful that it is the person's home. And even though, yes, I appreciate it is also a workplace for the support workers who are going into that home, to respect the fact that it is their home and it is their choice as to how they live. Mm-hmm. And, I know that support workers experience behaviours of concern. They're raised with us, usually around the withdrawal of services if they can't, come to some sort of compromise or arrangement with the older person. Staff training, as we all know, is crucial in every part of aged care. If we can train our staff properly, adequately, give them the resources that they need, we will improve aged care services.
Great. Thanks, Deborah. Richard, have you got anything to add to that?
When we were asked to do this webinar series, I think one of the questions I asked was, are we including community aged care in it? And the answer was no. But all that really meant was when I've prepared my talks, I've probably cut out the word community and put in the word aged care facility. I don't think anything that's been said in this webinar or the previous webinars really is precluded by someone being cared for in their own home rather than in an institution. And I kind of wonder, if someone's in their own home, it might be a little bit easier to gather trauma-informed history or provide trauma-informed care and gather a history, because people are kind of on their own turf. They might feel a little bit more confident to open up. Often when people are on our turf, in a hospital or in an aged care facility, they're kind of a little bit reluctant to disclose things. But in their own homes, perhaps they're actually a little bit more willing to. So it may actually, easier maybe isn't the right word, but it might actually work to your advantage if you follow some of these principles in community aged care.
Great.
And if I can add to
Yeah.
that in a home, it's being particularly attentive to then what's happening with the family and the family dynamics. So there may be traumas that are related to abuse by the family member or isolation from or conflict with. So it's important to make sure, again, that privacy principle might be more complex to manage at home, and being very conscious of that and who's present in the home. Because even if you have someone 3 doors down, but you feel intimidated by them, it's really hard to tell your story if they're in the house, for example.
Great, thank you. Just there's lots of questions coming in, and there's a real theme or interest in knowing, what do you do about managing if you're talking about trauma where this might cause the person to become quite distressed or triggered? How do you get this information about their trauma history without distressing the person too much? Anne-Laure, have you got any tips on that to start off with?
Yeah, I think to reiterate what Richard said, that often as practitioners, we have a real fear that we're going to distress people if we ask those questions. And that when people are vulnerable, particularly when they enter an aged care facility or they have dementia, that, if it's not impacting on their capacity to tell their story, that we feel reluctant to talk about something that's difficult. We think we're going to do harm. So to say that often people actually welcome telling their story and feel heard and understood. So often that's the experience rather than a harmful experience. But that's also important then to have time. That time is actually the biggest protector here. That if you have a rushed conversation that's tick and flick, you're just going through the list of many things you have to do in your assessment, and that's one of the many things you have to tick through, then that's a potential to harm. But if you have the space and time to just hear the story, that's going to contain the person and much less likely to trigger distress. And remember that even if the person gets distressed, they've thought about this on their own. They've talked to other people and have become distressed. This is not the first time that they will be distressed about it. And it's about sitting with them, helping them breathe, have a cup of tea, have a bit of time to calm down. And often that's enough. And also then making sure that you, as a person, as asks a question, you get supported afterwards. You get to talk to a colleague or your supervisor and say, hey, I had just heard someone really distressed. My heart is still going, just to let you know. But often people get distressed and then they're fine. That's also important to know. This is not the first time.
Yeah, and definitely, in the training that's being put together for this sector, that there's some of the, how do you have those conversations? How do you contain? How do you deal with that type of distress? There's some key strategies which are being, part of that training package. Deborah, I'm wondering though, in cases like that, what could you tell the family in terms of communicating with the family about why the resident might be, their loved one might be distressed? How do you prepare them to be able to also support their loved one?
I think to recognise, firstly, that a lot of families, particularly when people are entering residential care, if we just go back to that, are experiencing their own grief and their guilt about placing their loved ones in care, so they can be quite hypersensitive about it. So to be kind and compassionate and bear that in mind. Providers will often say to us, this family member is too difficult to deal with, we can't deal with them, they're being aggressive, etc., etc. When in actual fact, the family member is just very stressed about what is happening for their loved one, in particular if they feel that their loved one is not going to cope because of past trauma that the family member is well aware of. So again, I would say it's about building trust with the older person, but trust with the family as well. Feed back to us. Let us know what you experience. Let us know what you want from us, and then act upon that, as opposed to blaming them for their reactions to the situation. Because what family tell us is they're feeling very guilty that they're having to give up the care of their loved one to another party. And again, going back to, and it's a theme in a way. Include families in all of the care planning discussions.
Great. Thanks, Deborah. And an observation that's been made in the chat is that we've talked a lot about getting a trauma history of people as they're coming in, a new admission into care. What about those people who've been there for a long period of time? Is it appropriate to be trying to get a trauma history, and how much you go about doing that? Richard, are you able to comment on that?
It's never too late. If someone's come in and you've missed the opportunity, things change, something arises, and you think that could be a useful tool in caring for them, yeah, just the principles are the same. I would hope that all people coming into aged care have a really good trauma history taken, but if that opportunity's been missed or wasn't available to be done, I don't think it matters how long someone's been in aged care. I think everything we've said is equally pertinent to that case.
Great, thank you. And then we're about to run out of time for questions, but a question that keeps coming up is about the level of training that someone should have before they should be trying to take a trauma-informed care history or find out about a trauma history. And Laura, are you able to give any guidance on what training people should have done or what sort of experience they should have before they're trying to do this?
So you don't need to be a mental health worker to do this, but you do need to have some experience, especially at that assessment stage where you're sitting with someone and taking the history as Richard described. So if you're taking a formal history, having a bit of experience and some training in trauma-informed care. And again, we have one course that's more basic that's now available from today, and then we'll have more in-depth courses available free of charge for the aged care sector. But in the meantime, if you've had some experience, that's more important. So someone, for example, that's a lifestyle coordinator that's worked in the sector for a long time as a personal care worker that feels confident and has some support and training, that would be fine. Or nursing, someone in a nursing position, but someone new and that hasn't had a lot of training, it would be setting them up to do that. Having said that, as listening to someone tell their history, there's something that happened to them as a trauma, which may happen in a care facility. So someone tells you about something, you don't need to have any kind of training to ask that question. So there will be times, if you're trauma-informed in your approach, if you have relationship and you're warm to people, where they will disclose to you naturally. They say, oh, I don't like it when you touch me because I was assaulted when blah, blah, blah. And there you'd need very little training to be able to sit, listen, and then let someone know to put it in a care plan. That's different. You don't need that much training for that. And again, the trauma awareness course that's open from today on our website can help you with that aspect.
Yeah, that's great. It's like a life skill, isn't it, to be able to be comfortable and know how to engage with someone who has told you about a trauma history. That is all the time that we have for the webinar today. So I'd like to thank our panel very much for joining us and for the insights and expertise that you have shared with us in the presentations, but also in this panel discussion.
All right.
We'll now launch a poll, which you can access in the Q&A section below the webinar stream. We'd really appreciate you completing this very brief 3-question poll. This helps us to improve our services and also future webinars. While you're completing the poll, again, I'd like to thank you all for taking the time out of your day to attend and learn about the impacts of trauma in aged care settings and to talk about some really practical skills and strategies and tools that you can apply, and some of those that we will be releasing products that you'll be able to find, including on this website, some which are just been released and others will be coming out over the next few months. We really hope you found it informative and helpful, and a recording of this webinar plus the previous two will be on our website if you'd like to refer other work colleagues to view it. Again, thank you so very much to Deborah, Richard and Laura and Roz for sharing their great expertise with us on this important topic. We have one more webinar planned in this series. On the 16th of June, we'll be focusing on supporting staff wellbeing. This is a very important issue and it's one that can be easily overlooked amongst a really busy sector. As I said, over the next few days, we'll email you a link to a recording of the webinar, as well as more information on where you'll be able to access a range of the resources and training over the coming months as they're developed. And again, you can also go directly to our website for more information. Along with that link, we'll also send some information about a research project that Phoenix Australia is currently conducting to help us better understand the psychological impact of working in healthcare during the COVID-19 pandemic. This has a very particular focus on moral injury and distress, and some of you may be interested in participating in this research. Again, thank you so very much for your time today. We hope that you'll stay in contact and join us for future events. Thank you.